before he finally had a successful case, so he finally had a patient he thought was a good candidate. And Robert Glover actually gave him privileges. He didn't have privileges as Episcopal, and Robert Glover actually gave him privileges at Episcopal to let him try this operation. And of course, the rest is history. I mean, I'm sure it would have eventually happened, but at any rate, he did play a role in the first successful mitral commissurotomy. Now, this is Dr. Davlis. His wife was kind enough to send me these pictures, and this is his mitral insufficiency needle. Here's a picture of him at age 90 last July. And here's the paper that he presented at the AATS meeting in 1955 in Atlantic City, entitled Circumferential Suture of the Mitral Ring. And here are the pictures from that presentation. I have a copy of the paper, but unfortunately it's not a very good one because it was a Xerox copy. And this is Dr. Davlin. If you think we have some choices today, this was the choices they had back then, trying to figure out what's the best thing to do for the patient. So here's the early valves and pacemakers, etc. So what is best practices? Actually, the Health and Human Services has a definition of best practices. I'm not sure we'll meet any of that, including research validated, field tested, and promising practice. We probably fit most into the promising practice because, as you know, in mitral surgery, most of it's consensus opinion, what we call level of evidence C, but there is some more and more level of evidence B, but there's certainly no level of evidence A, controlled randomized trial. And again, this is from the AHACC guidelines from 2008, the review, and for class 1 indication was a symptomatic acute MR. Symptomatic MR with and without LV dysfunction, so any patient that has symptoms. And finally, mitral valve repair is preferred to mitral valve replacement, and the patient should be referred to a repair center, but that's level of evidence C. So what is class 2A, which is probably beneficial? I would say most of the patients that I see, and I usually put this in my note, the note I dictate to the referring doc, I put in this patient has a class 1 indication for intervention or a class 2A indication for intervention, just to clarify in case I have to meet with any Philadelphia lawyers. So in class 2A, you have asymptomatic with preserved LV function where the likelihood of repair is greater than 90%. Asymptomatic with preserved LV function and new onset atrial fibrillation. And I could not believe this is level of evidence C, that you have no evidence that this is beneficial to the patient. And finally, asymptomatic with preserved LV function and pulmonary hypertension at rest greater than 50 or with exercise greater than 60. Again, level of evidence C. And finally, severe LV dysfunction, less than 30% with a high likelihood of repairing a symptomatic patient. So class 3B, which obviously plus or minus of whether it will help the patient, there's secondary MR secondary to severe LV dysfunction with symptomatic heart failure, and Robert Dion is going to address that, so I'm not going to address that. Class 3, which shouldn't be done, asymptomatic, severe MR, preserved LV function, unlikely to get a repair. I guess we could discuss that. And finally, mild to moderate MR should not be operated on. So what about the asymptomatic patient? Because I certainly spend a lot of my time evaluating asymptomatic patients, and usually what's happened is the patient's seen an outside cardiologist who's told them you need an operation, go see Hargrove and he'll fix you up. So of course, Amari Serrano from the Mayo Clinic, and you saw this slide earlier, analyzes severe MR, thinks severe MR is analogous to the ASD, particularly in high volume centers where the mortality is very low and the chance of repair is very high. And as you can see, as your ERO goes up, your chance of some type of cardiac event, which includes sudden death, is fairly substantial within 5 years. It's 60%. On the other end of that spectrum is the Rosenheck paper from Vienna, where entitled Outcome of Watchful Waiting in Severe Asymptomatic Mitral Regurgitation. Now, this was 132 patients that they followed for 5 to 8 years. 32 developed criteria by the European guidelines for surgical intervention. 32 underwent surgery and 4 refused. There was no operative mortality, but 8 patients died in the follow-up period. That's during that period of time, and 5 of those were cardiac deaths. 3 were non-cardiac. So you wonder whether you might have saved at least a few of these 5 deaths. And here are the graphs from that paper. The left one is all patients comparing expected survival to survival in patients with the flail leaflet, and there really weren't any difference, although the event-free survival was somewhat better in the patient with just prolapse as opposed to a flail leaflet. And again, they were followed up to 8 years. And so their conclusion was that in asymptomatic patients with severe MR, that they can safely be followed until either symptoms occur, until the recommended cutoff for LV size, which Randy's talked about, LV function or pulmonary hypertension are reached. Again, I show you this slide. I mean, I actually have, when I discuss with patients in the office what I'm going to do, I basically go with this. Again, we got to go back. We have to have we need to know what the valve lesions are, so we need an accurate valve analysis. And once we get there, we reestablish the surface of coaptation, and we do some type of annuloplasty. Now, Patrick Perrier gave me this slide. I like to show this to the patient because I can show, here's the way your mitral valve is supposed to work. You have a flail leaflet or a flail anterior leaflet or posterior leaflet. And the idea for us is to ultimately restore this surface of coaptation to give you a good function. So what are the expected outcomes based on the literature of intervention for degenerative mitral disease? Now, we're not talking about rheumatic or functional MR for LV dysfunction. So the longest paper we have is, the longest follow-up is from Carpentier's group, published by Brownberger in Circulation Supplement 2001 on the 20-year history of repair in non-rheumatic mitral insufficiency. Not working. I don't know what's going on here. It's not.
Are you trying to advance it?
I'm trying to advance it. It's not working anymore.
With the advancer?
Yeah, I'm trying to advance it with the advancer.
Can you do it on? Can you?
I'm
do
trying
it?
to. Well, here, let me unplug it.
Just do it yourself. Come on.
What?
You're a surgeon. You can figure this
I know,
out.
but I'm not a. Huh.
What is he trying to do?
He can't get. He's got a Flemish Bubba locked up with another Bubba. Are you stuck?
I'm stuck. Yeah, I can't go back or forward.
Well, we know how long you've been going, though, don't we?
Yeah, we do.
He's
I'm
frozen.
stuck. I'm wondering what's going on. Asked from Baumberger's paper, and you notice here that your incidence of reoperation, posterior leaflets, the dotted line, anterior leaflet of both leaflets are here. So at 20 years, the incidence of reoperation was 5% in the posterior leaflet, but 20% in the other ones. The other thing I found interesting about this paper is that they did overall survival versus expected survival. It was actually a decrease in overall survival versus expected survival. And perhaps it was because they intervened too late in these patients. But now, the issue is the recurrence from the freedom from reoperation versus the recurrence of the freedom from recurrent MR. This was from Tyrone David, who many people consider one of the best surgeons, or if not the best surgeon in North America. It's a 20-year period from 1981 to 2001, and his freedom from reoperation overall was 95%, with the anterior leaflet being a little worse. But his freedom from recurrent MR, meaning 3 to 4 plus MR, was only 73%, meaning that over a quarter of the patients within 12 years of surgery had what we would call severe MR again. And again, he broke it down in by leaflet. Anterior leaflet was worse, bi-leaflet was about the same, and posterior leaflet was a little better in terms of freedom from severe microregurgitation. And this is somewhat more or less echoed paper from the Mayo Clinic by Rakesh Suri. Again, a 20-year period from 1980 to 2000. You could argue the early years of mitral repair. Over the period from 1980 to 89 versus 90 to 2000, they did improve, and their particular results with anterior leaflet improved. If you looked at the linearized risk of reoperation, it was lowest in the patients with the posterior leaflet repair, which more or less compared to the reoperation rate with patients in mechanical diseases, and bi-leaflet and anterior leaflet were much higher. In 2012, the group from Mount Sinai, Dave Adams, and Ani Anyawu, who's here this morning, published a paper, near 100% repair rate for mitral prolapse is achievable, and the implications for future guidelines. And this was a paper with 744 patients that were operated on between January of 2002 and December of 2010. They had a 99% repair rate. The mortality was less than 1%. The stroke rate was less than 1%. 75% had isolated posterior leaflet pathology. And it was a lesion-directed approach to repair. Obviously, they didn't just use cords or resection. They used a combination depending on the pathology. And here, their freedom from recurrent MR. And so the freedom at 7 years from 3+ MR was 96%, and the freedom from 2+ MR was 91%. So you wonder, when 5 more years are up, are they going to be fairly close or to what Tyrone's numbers want? It looks like they probably will be a little better, but we still have failures. And they go back to Randy first, and then he calls me. So it's not a great relationship when that happens. What's that?
It's not nice.
No, it's not. So what are the surgical techniques? Well, if we look at anatomy of leaflet prolapse, we know from almost all the studies that the isolated middle scallop of the posterior leaflet makes up about 70% of the mitral regurgitation. And in this group, I'm sure there are others that'll disagree with me. I think a simple operation, a triangular section and a ring or band, is the way I do. I don't think you need to make anything complicated. So the issue is, what do we do about the other 4 categories, which make up 25 to 30% of most people's practice? Some of these I just show you for historical reasons, because when we all went to see Carpentier, he had all these types of chordal shortening procedures, including papillary muscle trench, papillary muscle sliding plasty, chordal plication, and papillary muscle repositioning, which I think still has a place in commissural prolapse, which I'll show you in a few minutes. But early on, the group from Cleveland found that chordal transfer was much better than chordal shortening. I think chordal shortening was a treacherous operation. If you look here, freedom from reoperation with chordal shortening was only 75%, whereas 90% in chordal transfer. And you see here chordal transfer. Most of us today, I still occasionally use chordal transfer in maybe an anterior leaflet prolapse, but for the most part I would use Gore-Tex cords. Chordal transfer does have some advantages. It's simple. It's at the leafless level. It's reproducible, and the Lord measured it for you. And I can tell you the Lord's a lot better at measuring things than I am. The disadvantages, there are obviously some role of the secondary cords in the structure and function of the mitral valve, which I don't think have been truly elucidated, and also the fact that you may be transferring a diseased cord. So Bob Frater, I think, came up with the concept of replacing the cords with some foreign tissue. Initially he used tan xenograft pericardium, and ultimately he used PTFE, and showed that they work very nicely in long-term replacement of diseased cords. The advantages is they're available and they're durable. Obviously, the disadvantages is they're somewhat difficult to measure, and you have to put a lot of knots in the Gore-Tex or it'll come untied. Now, Fred Moore, I think, certainly popularized the loop technique, where you take this caliper and you measure the length of the cord you want to replace, and then on the caliper you make this loop. This is a fairly complicated process. Then you attach it to the papillary muscle, and then again to the leaflet edge. Now, these are available commercially in Europe from Santec. The posterior links are most commonly 14 to 18, the anterior 20 to 24.
Incredible.
Unfortunately, Genesee Medical is talking to us about making some, but we still don't have these commercially available in the United States. There is a simple way to make them, and I'll show you in a paper described by Tan that I recently learned. And this is a Mark Gilanoff paper, How To, and it just shows you how to make the cords. It's a fairly laborious process, I can tell you. Again, always respect the midline when you're using artificial cords. This part goes from the anterior papillary muscle, this one from the posterior papillary muscle. And if you look at Fred, if you talk to the people from Leipzig, they rarely do a resection anymore. I know Robert, I'm sure he'll chime in about the issue of if you have the posterior leaflet fixed or whether you want it to move. I'm not sure it makes any difference, and you're fixing the annulus in the systolic position. Ottavio Alfieri has shown us that you can use the edge-to-edge repair, creating a double orifice mitral valve, and also with commissural prolapse, and get equivalent results to resective techniques. Here, overall freedom from reoperation at up to 10 years, comparing anterior prolapse and posterior leaflet prolapse. Now, how about the commissural prolapse? Obviously, this commissural area, you notice the fan cord. Gilles Dreyfus has described has a nice series where he shortens one of these three. Usually, this papillary muscle has three heads, and by shortening the middle one, you can pull all of these cords down at the same time. Of course, the other thing you could, if it's a big enough orifice, just oversew it and put a ring in. It's a lot simpler. I thought I'd spend a minute or so on Barlow's valve. Now, if you go back and look at Barlow's original paper, he didn't have any echo. He had patients with systolic clicks and late systolic murmurs, so he sent them for cath, and all of them had MR. And so what we describe as a Barlow's valve, I'm not sure was what he really described in his initial paper. About 20 years later, he came out with the paper which showed all forms of possible, from billowing, floppy, prolapse, or flail mitral valves. And this is a figure from the paper show you. You remember Carpentier's talked about the difference between prolapse and billowing. So this would be a billowing valve because the leaflets are above the plane of the valve. This is obviously flail. Now, one other thing about Barlow's valves is it's almost a uniform echo finding of this disjunction of the mitral annulus in the floppy valve. And this was a paper from Hopkins from 1986. And you can see here, when you see this, where the annulus goes backwards during systolic contraction, you almost know for sure you're dealing with the Barlow's valve. Now, you've seen this slide before, and now Randy says it's more difficult the further you go down the spectrum. I mean, I think this is probably the easiest valve to repair with an isolated P2 and plenty of tissue, but I think this is a lot easier to repair than a patient with a very thin leaflet and fibroelastic deficiency, because if you got too much tissue, I can make it competent. No matter how bad it looks, and this is a paper by Yanni and Dave. It just shows you how ugly some of these valves look. But the only thing you have to worry about is SAM. So if you follow Patrick Perrier's advice and make this A, B, C a relatively straight line, then you generally won't get SAM in these patients. And I promise you won't have a leaky valve. So in the modern era, repair for degenerative disease, I think, falls into respect or resect with respect. I misprint there. respect rather than resect. You use neocords liberally. You use the edge-to-edge repair when you need to. And finally, you need to put in some type of annuloplasty ring or band. And what all these techniques do is they preserve leaflet tissue and increase the surface of coaptation. So, how do we approach the mitral valve? And I'm not going to spend a lot of time here. Should we do standard sternotomy or a minimally invasive approach? But if we look at the continuum of mitral valve repair surgery up until the 60s, they've all been done through thoracotomy. And then central aortic cannulation came about in the 60s. Of course, Carpentier started his work in the 70s. And when I was a resident, we would use right thoracotomy principally for redo mitral valves because we wanted a virgin field. Heart port technology came out in 1996, and the robotic mitral valve surgery started in this country by Dr. Chitwood was first done in 1998. And of course, the MitraClip, which I believe we're going to hear a little bit about tomorrow, was introduced in 2004. Regrettably, that's not usable by us right now. So here's our preferred method. We use peripheral cannulation, the endo-aortic occlusive, balloon occlusive, and you can see the patient has a small right thoracotomy, cannulation via the groin. Usually we put in a neckline also. And you can use the robot if you wish. The relative contraindications are severe peripheral vascular disease. You can use the nominate artery if you want, if you really want to do this, or you can do what we call endo-direct and cannulate the ascending aorta directly. Severe mitral annular calcification, I've had difficulty decalcifying the mitral valves from this position, so generally I recommend a sternotomy in that case. And finally, a previous right lung resection. I've done plenty of people with previous right thoracotomies, some of whom did the first operation on, so it's not usually a problem going back. But if they had a lung resection, I think it is. And this is a method that many prefer. It's simpler, it's cheaper, where you put a cardioplegic needle in the ascending aorta and use a cross clamp. You can also use a hemisternotomy. I haven't really done this. I don't really see much advantage of it, but maybe Saeed Farivar, who's had a fair experience with this, can address it. So, obviously, a lot of people have thought a lot about this. In 2011, ISMICS came out with a consensus statement based on about 30 papers. I think it were 32 papers in the literature on minimally invasive versus open mitral valve surgery. And the summary and conclusions were that in patients with mitral valve disease, minimally invasive surgery may be an alternative to conventional mitral valve surgery, class 2B. So, plus minus. There are comparable short and long-term mortality, comparable in-hospital morbidity, but reduced, obviously you can't get a sternal infection if you don't have a sternotomy. Less transfusions, less post-op AFib, duration of ventilation, and ICU and hospital stay. However, that should be considered against an increased risk of stroke, in the cases 2% versus 1%, aortic dissection, phrenic nerve palsy, groin complications, and prolonged cross-clamp and cardiopulmonary bypass times. So what is the state of affairs in the United States? So this is a paper Jim Gammey presented at the AATS in the STS in 2010. It was the Chamberlain paper. It was an STS database paper based from 5-year period, 2004 to 2008. There were 28,000 and change isolated mitral operations of over 144,000. There were no redos or endocarditis included. And the inclusion was based on the cannulation technique. It's only in the most recent STS iteration that the type of incision that we use is included. So it was an inference paper. But despite that, the limited invasive mitral valve surgery increased from about 12% in 2004 to 20% in 2008, with about a quarter of the centers doing at least one, but the median number of cases being 3. So it was a definitely Pareto phenomenon where you had 95% of the cases were done by 5% of the surgeons. 35% use robotics, and 30% the aortic endoclamp. And this is a summary of the data from the paper, the standard sternotomy and the limited invasive. The age was lower, so you might argue that they picked better candidates. Cardiopulmonary bypass was longer. There was less blood used in the limited invasive. There was no difference between the Chitwood clamp and the endoclamp, but the incidence of mitral valve repair was significantly improved over sternotomy, and I suspect because most of the operations here will be done by people that had a specific interest in mitral surgery, but that the stroke rate was higher in the limited invasive, particularly in those patients who had fibrillatory arrest. So, don't tell me, I'm locked down again.
You locked up again?
Yeah. Well, my last slide was, so the best practice in 2013 is mitral valve repair is the standard. The management of the asymptomatic patient is still being debated, and the operative approach is currently surgeon-driven. Thank you.
Good. Okay, any questions? Dr. Chitwood, you were the commentator on that paper. What'd you say? Yeah.
No, yeah.
Yeah, the GAMI paper.
I don't remember what I said. To be very honest, I think the one thing I had difficulty with was the VFib strokes, because basically we've not seen the same level of strokes with that, and you know, and I was also surprised that because of the early risks with the endoclamp, the balloon, that there was no difference between just a straightforward cross clamp. But I think also this was inexperienced people too.
Well, no, it's everybody in the STS. And well, you got to remember, it's from 2004 to 8.
But as you said, most of the cases were done by a few folks, right?
Yeah, they were.
So you know, I mean, I don't remember what I said at the meeting. I mean, I supported it, except I think I stood up and said that the stroke rate was probably higher in the VFib, and that's probably not necessarily true. Even though Dr. Bowling's paper found that basically beating heart versus VFib, it was probably better to do beating heart, but I think the stroke rate was the same in both, wasn't it? So there's no difference in beating heart and stroke rate in the re-ops.
We're gonna have a talk this afternoon, 2 talks this afternoon on this, so it'll be interesting to get that opinion.
Steve, you want to comment?
So, yeah, Steve, you want to?
So, I mean, I saw Randy stand up and give his comments. I actually remember what he said. I'm a lot younger than he is. But, you know, I think part of the problem looking at that is the database problem. Before 2011, we didn't have a good handle on the database and what it really meant. The other problem is, you know, you can't really think of the number of 3 as being an average because it's such a skewed population. You really had, you know, 95% of the cases done in a very small number of units, and then if you take those units away, then everyone else was doing 1 or 2, you know, minimally invasive mitral a year, which of course is almost meaningless to look at those numbers. The stroke rate is, you know, always going to be proportional to the length of the cross clamp time on bypass, and if it takes you forever to do that, your stroke rate is going to go up. Our paper, we looked at 450 redos we did to right thoracotomy, and our stroke rate was very low. But we do a lot of them that way. So, you know, I'll talk it in my paper. It has a lot to do with the volume of the center, the volume of the surgeon that's doing it. I think that's what Randy said.
So Clark, let me see if I've got. So what you're saying is that as we've evolved now, we resect less. You guys resect less.
Absolutely.
And that, do you think that where I'm going with this is I'm bothered by Tyrone's paper. I've always been bothered by that, but that's, you know,
that's the early experience.
Along, right, okay. Right. So do you think that a lot of the failures are due to over vigorous resection, so leaving a little bit of tissue at P3 or something
clearly
like that?
In the old days, Carpentier said if you cannot do a triangle resection, you must do a quadrangular resection, sliding plastic. I think the more complicated you make the repair, the greater chance you're going to have for failure. I mean, it makes sense to me.
So where I'm going with this, because I'm going to show the same case that Dr. Bowling started chewing on me. It was like a rabid, tall, skinny dog coming after me last year on this guy who I followed for 12 years. You know, and that was exactly the reason we followed him. Is that, you know, number one, he didn't show any change, but number two, he's very smart, and he had actually reviewed the literature and said, look, if in 20 years or 10 years I'm gonna, you know, I've got a 20% chance of having to have this done again, I think I'm going to wait and let these guys get better. Is that the right choice?
Well, I think we are better. I think we still have failures. I mean, I think if you look at the failures, about 70% are currently attributed to surgeon error and 30% to progressive disease. Now, so do I have, sure, I mean, I have people that operate on 10 years walk up to me in the bank and say, you operated on me. And I said, you remember me? I said, sure. You know, but,
you know, I think we have less failures now because basically I think we're doing less of the valve.
That's
what
I'm getting at.
We do these big sliding plasties. I try to not disrupt the annular leaflet integrity if possible. If I'm doing a triangular or trapezoidal, it doesn't go all the way to the annulus. Right. You know, you get a little pucker at the end and you can kind of tuck it down. And basically, I think that's where you got a lot of failures was, you know, when you were horsing the old Carpentier technique where you did a quad resection, a large resection, and you put a big pledgeted suture and pull the annulus together. You can imagine the stress related there. So I think we're doing less stuff. And I'll be really...
now, comment